to raise your hand, we will know to acknowledge you and to unmute your line. If you hover your mouse near the bottom of your screen, that's the creature stirring mouse, of course, you will see the participants tab. That can be expanded if you would like to see it. It will list everyone who's on the presentation. The chat feature is also at the bottom of your screen as well. Once you maximize it, you will be able to chat with the presenters or others during the meeting. We will not be using a polling question tonight during the meeting. You would simply click on your answer and hit submit if there are any at the end of the presentation. If you need to step away, you can stop sharing your camera by clicking on the camera icon at the bottom of the screen. You can click on it again to start sharing your video camera again. Concerns or complaints can be directed to the State Ombudsman Office at 717, and you'll see that Jay has put that on the chat, 717-783-8975, or by email at ltc-ombudsman@pa.gov. Thank you. I'm going to turn this over to Carol Diefenbaugh, who is going to introduce our speaker tonight.
Thank you, Jeannie. It's my honor and privilege to introduce Linda Shumaker, RN, BCMA. Linda Shumaker is a gerontological certified registered nurse who is a private consultant as well as currently in a clinical practice in Harrisburg. She has previously served as the outreach coordinator of the Pennsylvania Behavioral Health and Aging Coalition. In 2005, as founding executive director of the coalition, she advocated for funding and received over $325,000 to outreach and educate older adults regarding behavioral health issues. She introduced policies to encourage the mental health and the aging systems of care to work cooperatively to serve older adults with behavioral health issues. Ms. Shumaker has also served as the executive director of Prevent Suicide PA, a statewide nonprofit to support those affected by suicide, provide education, awareness, and understanding by collaborating with the community to prevent suicide and reduce the stigma associated with that. Ms. Shumaker spearheaded the Pennsylvania Older Adult Suicide Prevention Plan, which was one of the first in the country, as well as advocating and obtaining a mental health bulletin, ensuring that adults with dementia and secondary psychiatric symptoms have access to mental health treatment. Ms. Shumaker also has worked with the Central Pennsylvania Psychiatric Institute, Pennsylvania State College of Medicine in Hershey, Pennsylvania. Ms. Shumaker has extensive clinical experience working in the community mental health field, geriatric assessment teams, and also in long-term care. In addition, she has been an instructor of psychiatry at the Pennsylvania State University College of Medicine, the co-chair and founding member of the Pennsylvania Mental Health and Aging Coalition. She has served as a member of the Older Adult Committee of the Pennsylvania Office of Mental Health and Substance Abuse Planning Council, and as a member of the Long-Term Care Subcommittee of the Medical Assistance Advisory Committee. Ms. Shumaker has also served on the Ethics Committee of Temple University Protective Services Institute. She has served on the board of directors for the Pennsylvania State Alzheimer's Association and the advisory board of the Central Pennsylvania chapter of the Alzheimer's Association. She currently serves on the board of directors for the Pennsylvania Association of the Blind. Ms. Shumaker's special interests include ethical and social policy issues in relation to the care of the elderly with behavioral health problems. Please help me in welcoming Ms. Shumaker.
Thank you. I thought we talked about abbreviating that. So yes, I am a registered nurse and I actually am in clinical practice.
Sorry, that's my fault.
That's okay. I just hate to hear it. I use it for other purposes, so I really hate to hear it. But anyhow, so in other words, I'm very old and I've been doing the same thing for a long time. So I actually have worked in geriatric psychiatry since 1979. I fell into my niche early and I love what I do and I'm very passionate what I do. And that introduction obviously speaks of my passion. So this evening, what I am going to talk about is just how depression, dementia, and delirium affects older adults. And I'm going to talk about each one of them. And the reason, and I can't stress this enough because I do work in a clinic 4 days a week, why this is so important. First of all, because delirium, depression, and dementia are really psychiatric disorders on some level. And because of stigma issues with older adults, and because just of system issues, it is really older adults are an underserved population. So we're going to talk about some of that, which is why older white men have had one of the highest suicide rates for decades, and nobody has really addressed it or talked about it or the emphasis on it. And Pennsylvania was the first state in the country in 2005 to have a suicide prevention plan specifically targeting older individuals. And believe it or not, older men back then had the highest rate of suicide in the country, but the emphasis is and continues to be on children and kids. Now the populations have changed and suicide has increased actually among different populations than older white men, but it's still a pretty severe, high rate with older white men. So the big problem is that the growth in the population is actually in the aging population is huge. It's going to be from 12 to 21% by 2030. And the growth in this population is expected actually among the oldest and the most frail population groups, simply because we are living longer and because the population, the boomers are coming in, and that's the hugest population. The other big issues is that the aging population in our country have multiple comorbidities and multiple health problems, which we're learning about, unfortunately, in the essence of COVID. So Jamie, I show that my video is on and I keep looking for it, so I hope it's okay. Anyhow, so the emphasis is with these three diagnoses, the depression, dementia, and delirium, is number one, many age-related losses, many physical problems increase the risk of depression in older adults. We know that the risk of dementia increases with age, and in fact, age is the greatest risk factor for Alzheimer's disease. And because of those comorbid disorders, the hypertension, the diabetes, all of those complicated medical problems can predispose older individuals into delirium. So that recognizing and differentiating these three diagnoses is extremely important, and not just to healthcare providers. It's also extremely, extremely difficult. So I have some medical slides in here, and I'm going to try and address them in a much more lay lay approach. So if you have questions at the end, we can talk about it then. But so this is the difference. Delirium and dementia both affects cognition. So they affect your memory. They can make you disoriented and things like that. But depression as well can also make you feel like you don't know what's going on and you're disoriented. And my mother, in fact, had suffered from late life depression. And she actually kept telling me, no, I really have Alzheimer's disease. I can't remember right. And the difference was she could remember, but she felt like she couldn't remember. And those types of things, that differentiation actually tests out in psychological testing when you're doing testing on an individual. Okay. The thing to remember is that dementia mainly affects memory. Okay, so people won't know where they're at. They may not recognize people. They may not remember how to cook or how to brush their teeth or things like that. When somebody gets delirious, it mainly affects their attention. So they're literally not able to attend to the point at hand. They seem almost like they're hyperactive. They're sort of bouncing around with everything. Okay. And the other thing with delirium is people are up at night. They almost, with delirium, many times people don't sleep well and they're up rummaging and you can't get them to sleep. And then they're exhausted during the day and they may sleep, so that their sleep wake cycle actually gets turned around. Okay. And the problem is with these conditions, and even doctors have difficulty differentiating them. They're very complex. Many times they aren't recognized. And sometimes you can have people with dementia get depressed, and people with dementia can get a urinary tract infection and be delirious. So it's really important that we recognize these things and get treatment first. And the best thing to do, and I can tell you I did it today, is when somebody changes, when you see a change in somebody, and the case today was somebody who actually has a severe depression, and the daughter called me sleeping well, and she's up at night, and she's also saying that her memory is bad. And originally they actually thought she did have some form of dementia, but when she got treatment, she was totally fine. And she's been fine for about the past 6 months, but she has a tendency to get depressed this time of year. But the first thing I said was, well, it's just her depression. I didn't say that. I said, the first thing we need to do is make sure that there's nothing medically causing this. So I had the daughter call the family doctor and maybe check a urinalysis and just see if there's any new medications and things like that. So you really want, whenever you see a change, okay, so the rule of thumb, anything that you get out of this tonight, is if you see any change in a person, you always think medically first. You don't say, oh, I think they have dementia, their dementia is getting worse. It's always, you need to give benefit of the doubt and make sure there's nothing medically that's confusing it. So you always take them to their family doctor so that they can get looked at. And it's really, if people don't get treated, their health can decline, they can get institutionalized, and it affects the quality of life, not only of the person, the individual, but of caregivers, because you're up at night with them and they're so restless and agitated, you don't know what to do. So remember, you always think medical first. And this is an old slide, but this just shows you how one of the ways that we teach people to recognize the differences between the three. So dementia is very slow and onset goes on for years. Delirium is acute, depression is gradually. Dementia, months to years. Delirium, people will fluctuate, hours. Depression's years. Dementia, people are conscious. They seem to know what they're doing. With delirium, 1 minute they'll be with you, and the next minute they may be sleeping, or they may be really agitated and not able to function. Okay. People with dementia, with depression, they are conscious and they're with you. Like I said, my mother was saying to me, I really think I have Alzheimer's disease. Circadian rhythm is sleep, Dementia, it's usually normal, can be upsetting at times. Delirium is usually disturbed. Memory is impaired with dementia. It can be impaired with delirium. It's usually normal with depression. Okay. Hallucinations with dementia. Delirium hallucinations are common. People will see cats and dogs and children in the yard and things like that. Okay. So that's just a simple slide to show you how it's one of the ways you can differentiate. So we're going to talk about each of these separately and then talk, and I'm not going to do a presentation because I figured you guys would do cases or talk about cases at the end, but we're just going to go through and talk about them. So depression in older adults is extremely common, almost 40% in primary care. Okay. So, and when I'm talking about a depression, I'm actually talking about a chemical imbalance in your brain. So many things can cause it. Okay. It can be caused by surgery with an older adult. My father had hip replacement surgery when he was in his early 70s. And when he went in for the surgery, he did extremely well. He's one of those central Pennsylvania Germans, listened to what they said, went to PT and everything. But when he got home, and about 6 weeks after he was discharged, he actually he got something from his insurance company, and what it was a geriatric depression scale. So his insurance company knew that as an older adult that he was at a higher risk of getting depressed. And I think that's really interesting because, and this was in 2001, and we knew that because I'm in the business, but the primary care physician or the surgeon didn't think of asking. So people after surgery can get depressed. And the reason, and it was certainly good patient care that the insurance company did it, but it was because they knew if he did get depressed, he would cost them money. And you can see this on the slide. Depressed individuals have a higher increased component of healthcare costs, except for mental health. Total healthcare costs for people who are depressed are 47 to 51% higher. Outpatient are 43 to 52% higher. So that's why that insurance company actually said, we don't want him to get depressed because it's going to cost us more money. It's not that it was a great clinical practice. And if you notice now, when you do go into your family doctors, whether or not you have that Medicare wellness exam, they actually ask you depressive questions in that paperwork that you fill out, whether or not you've been feeling sad, sort of like it depends on what you do, but they'll ask you those questions, which I think is really, really interesting. Finally, they are doing that. So depression can be physical, social, or psychological in origin. So the loss of a spouse, bereavement can move on to a depression. A health problem that limits activities, sometimes not being able to drive or not being able to get go out and socialize. COVID, with the isolation that people are feeling, has increased risk of depression as well. In fact, about 30% across the board. And we'll talk a little bit about that in a little bit. Medical conditions, Parkinson's disease, hormonal disorders, heart disease. I got asked to do a presentation when I was working at the Med Center at Harrisburg Hospital because the cardiac nurses were seeing a whole lot of depression after people would have heart attacks or would have bypass surgery, and they didn't know how to talk to them about it and what to teach them about it. So it is very, very common. People who have chronic pain frequently have depressive disorders as well, nutritional deficiencies, and of course, people that have genetic predispositions to depression are going to get it. So if your mother was depressed, or if your grandmother was in a state hospital, your risk of getting depressed as well, because just like diabetes and just like arthritis and just like breast cancer, there are genetic components to mental health disorders. And it's not that you did something wrong. There actually is a chemical imbalance in the brain. Okay. The chemistry in your brain changes, and what the medications do is reverse the chemistry so that you can sleep again and eat well again. And we're going to talk a little bit about the symptoms in a bit. So individuals who get depressed the first time in later life have a depression that's related to medical illness. Okay. Like my mother's depression, she got depressed because she had chronic pain from severe degenerative disc disease. And then she had surgery for that disease, for one of her discs, for getting it repaired. And she actually got depressed right after that. And I kept telling her she was depressed, and she kept saying, no, I'm not depressed. I think I have dementia. And her energy was down. It was horrible for her. And it took about 3 months to get her treated well and get her on medication that really helped. Also, even with post-stroke, what they do now with people who've had strokes, they'll actually put them on antidepressants, because up to 50% of people after a stroke will actually get depressed. Okay. The other thing that you need to know is this late life depression caused by these medical conditions. These are the older white men who attempt suicide, and usually who complete suicide. Older white men are the highest risk for completing suicide. Okay. So once again, late onset depression is depression occurring for the first time after age 60. It is usually brought on by another medical illness. We have no idea why it causes those brain changes, but it does. The problem is with older adults, when somebody is already physically ill, it's hard to recognize depression because the symptoms are very similar. Okay. People with depression are very apathetic. Okay. They may talk about their cognitive deficits. I think I have Alzheimer's disease, and they have less lifetime personality dysfunction, which means they aren't that type of depressed person who's been depressed all their life and talk sort of like that Eeyore type of person. The other important thing to remember is that depressive disorders actually can account for more disability than medical illnesses. So if somebody is depressed, they are literally wiped out and they can't get up and move. It's really hard to get them moving. And what we also know is that medical illness is the most common stressor associated with major depression, and is the most powerful predictor of poor outcomes. So in other words, if you have a lot of medical problems and you get depressed on top of that, that is a predictor of poor outcomes. So you really need to get that depression treated to make sure that your medical illness gets treated as well. Because if people don't get treated, it leads to physical illness, institutionalization, psychosocial deterioration, and suicide. In other words, people literally just give up. Okay. And I've seen people with severe depression. We had recommended that they have shock treatments done because it was going on, and this gentleman lost a huge amount of weight. Family was pushing him to come into the hospital, and he kept thinking that he had something medically wrong, despite multiple ER visits and medical workups. And they finally decided to put him on at first they put him on palliative care, and then he went on hospice, and he actually died. And it was very sad for us because we really think that he could have been treated and really could have been helped well. So what symptoms that you see? The main one is sadness. Okay, with older adults, however, sadness may be denied. They may talk more about what we call somatic equivalents, but their body aches and pains. I'm not sleeping. My arthritis is so bad. I'm constipated. Okay, and those are those two questions you'll see in the doctor's office. They'll ask if you feel sad, and they'll ask if you have a loss of interest or pleasure in your usual activities. Okay, older adults may also become irritable. Okay. Usually with older people, you will see an abnormal appetite with weight loss. There'll be what we call a sleep disturbance. And what that is, because many times as we get older, our sleep normally changes. We don't sleep as deep and we're in and out of cycles more quickly, so we don't feel as well rested. But with a depressed sleep, and you can see this because this all happens to us when we're stressed, like under COVID, this has been a really stressful time for many of us. And I'm sure what happens is we lay awake worrying at night. And then when we do fall asleep, we wake up it's called early morning awakening. So we wake up around 3 or 4 o'clock in the morning and we aren't able to get back to sleep. We lay there and worry again. Okay, so difficulty falling asleep and early morning awakening. And you're ruminating and you're worried and you're worried and you're worried. And that's a normal sleep when you're stressed. But when you're depressed, it happens every single night to the point that you're not sleeping at all. Okay. With depression, people also are fatigued, they have loss of energy, and that psychomotor retardation or agitation means they're slow, they just aren't moving fast, or they're really agitated and they're pacing and they're moving around and they can't sit still and they're restless. Okay, that's what psychomotor agitation and retardation have. The other thing that they get is abnormal guilt, inappropriate guilt, totally out of context. And they'll say, I'm a horrible person. We have a gentleman right now who's severely depressed. And we think he needs to be back in the hospital again, but he feels that he did something wrong with his mother's will, and he did not. He's an attorney. It was fine. Everybody tells him it's fine, but he can't. He is obsessing on that. Okay, so that's abnormal self-reproach or inappropriate guilt. There also is abnormal concentration or indecisiveness. People won't be able to make a decision, or you'll read something and you won't be able to remember what you read. Okay. There's also morbid thoughts of death, not just a fear of dying or thoughts of death. And there's thoughts of suicide. Okay. The other thing that you need to know about depression, it's not that you just diagnose depression like that, is that you, in order to have a diagnosis with depression, you think you need to have these symptoms consistently for 2 weeks or longer every day. So it's not like you're worried about COVID over the past month and you're not sleeping well a few days a week, but it's consistently. And consistently you've lost 20 or 30 pounds. Those are the things that can happen. So those are the things that you really need to be aware of. It's not just people whimsically diagnose you as depressed. We actually have in psychiatry, there's a book called the Statistical Manual, the 5th edition, that guidelines how you give diagnoses. And depression is these symptoms basically for 2 weeks or longer every day. And you don't just give it after 2 weeks. Usually people have suffered for a couple months. Okay. Now, I also wanted to mention depression and caregiving because it is a huge problem. And one of the things that has come out with COVID is the increase in caregiver suicide as the isolation has gone on with family caregivers. So suicide is actually going up, I think, at least 10 to 15%, the last statistics that I saw from August. So family caregivers do suffer from depression. And if you think about if you are depressed as a caregiver, your care is not going to be good. Okay. When they were talking back in 2005 and 2006, when they were talking about doing long-term living was changing and we were using waiver programs to keep people in the home longer. One of the things I cautioned, because I was working closely with PDA at the time through the coalition, I really said what we need to do is we know that caregiver depression rates are extremely high. So if we're keeping people at home longer, which yes, I think we need to do, I think it's what everybody wants, but we need to be aware of depression in caregivers. We need to be teaching people about it. We need to provide them with adequate education and resources, which is one of the reasons I was so glad to do this presentation. Okay. The symptoms for depression in caregivers are the same things, just what we just talked about. Now, the research from 1997, that was the original research. It has been replicated many times, and it actually is about 30% of caregivers suffer from clinically significant depressive symptoms. And my theory is that's where neglect and abuse can happen. So we need to make sure our caregivers are educated on what depression is, that they themselves should get support, which is why it's wonderful to see over 70 people on this call or on this webinar. So it's extremely important for you to use the resources, especially during COVID, that you use online resources, do support groups online with the Alzheimer's Association. These things are extremely, extremely important. Get educated. It's one of the things that we need to be doing. The other thing I want you to notice, and this is actually from Rick Schultz at Pitt, care recipients' behavior is the most overwhelming predictor of caregiver depression. So if your loved one is delirious and is up at night, that is a bad predictor. If your loved one is suspicious and things like that, that is a bad predictor. So don't be ashamed. You can talk to 93% of older adults actually get their psychiatric treatment from their primary care physician. We only see people who are complicated. It's okay to say to your family doctor, I'm not sleeping well, my appetite is bad, I have no energy, I'm irritable, I think I'm depressed, it's been going on for over a month. Do you think I need an antidepressant? And can you give me one? Okay, those are okay and good questions to ask. The only thing I want to caution you of, most antidepressants do take 6 to 8 weeks to work. Okay, so you're going to start one and you're not going to feel better the next day. It's going to take 6 to 8 weeks to work. Okay, you need to do behavioral types of things like continuing to push yourself to get up and get moving and do things that you enjoy, focusing on positives, those behavioral things until the medication kicks in. Now, with dementia, approximately 50% of people with dementia can get depressed. Average is around 30%, and symptoms are exactly the same: loss of interest, irritability, not eating, tearfulness, and decline in skills, not wanting to get out of bed, those types of things. And the thing to know is that most people who get treated for depression actually do very well. Do very, very well. But with late onset, there's many different types of depression, but that late onset type of depression, you should probably stay on the antidepressant the rest of your life. Okay. My mother actually, and they've known that research actually comes from University of Pittsburgh. They have a huge late life depression treatment center there. And my mother actually stopped her antidepressant about 3 months after she started it because she said she felt great. And I said to her, you shouldn't have. She really got depressed again. Tried putting her back on the Zoloft that she was on, and it didn't work, and they had to switch her. And it took 6 to 8 weeks to get her treated again. So the reason that they don't want you to go off is because there's a high risk of the depression coming back. And if you do want to go off, they will do that. They can take you off the medicine, but they're going to do it gradually, not because it's addictive or anything, but because if those depressive symptoms come back, they want to be able to just go right back up so you aren't depressed for 6 or 8 more weeks, letting the medication work again. Okay. So that is basically depression. It is underdetected and underdiagnosed. The first thing you need to do is make sure there's nothing physically causing the depression. It's not a thyroid, they aren't anemic, things like that. Remember, older adults have more physical symptoms and may have increased anxiety or agitation. Sleep disturbance is common, and we really need to use a person-centered focus in working with the individual, because they may not be that type of person to get up and wildly do things, but they're missing doing their Zoom church. You know, they're missing those things and they don't have the energy to do it. These are scales that we used. I just wanted to show you that there are actual scales. The geriatric depression scale is the main geriatric scale. It's been around since the late 60s. The PHQ-9, the patient health questionnaire, that's the questionnaire that you actually get in your family doctor's office. But there's many other ones. There's a Cornell scale that actually measures depression and dementia as well. Okay. So we're going to talk about dementia now. And I'm just watching the clock because I have a lot of information. So you guys probably know dementia has been around for a long time. The biggest problem with dementia right now is it's a major public health concern and this is new from the Alzheimer's Association, this is 2020, 5.8 million people in the US, 10% of individuals over 65. If there's no cure, it'll be 88 million by 2050. So it is huge. The majority of people with dementia are women. However, if you look at age-specific incidence, it's the same for men and women. Women just live longer, which I think is going to be changing in recent years. However, the risk of Alzheimer's disease is the same for men and women. We also know that people with lower levels of education appear to be at higher risk of Alzheimer's and other dementia, and that's multifactual. Okay. We also know that African Americans are twice as likely to get dementia. Hispanic individuals are 1.5 times more likely. That's actually due to health disparities that everyone is hearing about now because of COVID. But many of us who do teaching and health and aging have known this for 15, 20 years. These health disparities are why people are dying quicker in these populations and are why these populations are also at higher risk of getting dementia. So socioeconomic factors and health-related behaviors. Dementia is a chronic and progressive loss of intellectual functioning, gradually interferes with every part of your life. The Alzheimer's Association will say that Alzheimer's disease is the most prevalent type of dementia, 60 to 80%. However, many times when they go in and biopsy the brain with Alzheimer's, you will see other types of dementia under the microscope. You'll see Alzheimer's and Lewy body. You may see some of the vascular infarcts from a vascular type of dementia as well. Aging is the main risk factor. Okay. However, it is not consequential to the aging process. 10% of individuals over 65, 32% of individuals over 85. However, the good news is that number has dropped from 43% a few years ago. That's because people are getting their cardiac issues, their lipids and things treated, their hypertension under control, and their diabetes under control, because all three of those things, diabetes, hypertension, and increased triglycerides and cholesterol, increase your risk of getting Alzheimer's disease. So with those things being treated, the rates are dropping. Also, boomers are much more physically active, and we're seeing part of the boomer population factor into this now. So causes of dementia: Alzheimer's disease, cerebral vascular disease, or what we used to call vascular dementia or multi-infarct dementia. It's called by strokes, mini strokes, diabetes, things like that. Lewy body is a type of dementia that actually is different. Visual hallucinations may be the first symptoms. These people also have Parkinsonian type of things, Parkinsonian type of symptoms like shuffling gait, stiffness, and things like that. They also have a fluctuating level of consciousness, which means 1 minute they'll be with you, the next minute they won't. So that's Lewy body, but visual hallucinations are really, really one of the first symptoms with Lewy body. Frontal temporal dementia is the type that hits the frontal part of your brain. That the majority of thing that's in the frontal part of your brain is personality. So that changes. And that could be the first symptom as well. Parkinson's disease also About 80% of people with Parkinson's disease later on in the disease process will actually get a type of dementia as well. Okay. Jakob Creutzfeldt, that is mad cow disease. That's the one that comes from eating contaminated meat that also has some genetic component to it as well. There are also types of dementia that come from substance alcohol abuse specifically. Okay, that just shows you the majority of causes are mixed in Alzheimer's and then vascular fix-it as well as Lewy body. So the problem with Alzheimer's disease is the only true way to diagnose it is to biopsy the brain. But if you get a good medical workup done and get some neuropsych testing and maybe a psychiatric evaluation, sort of like what we do in our clinic, you can be 95% accurate with your diagnosis. Okay. There also are hereditary issues, but the hereditary ones, even people that have both of the most common gene, the APOE3 gene, there are people walking around with both sets of that gene and they are not getting the dementia. So once again, like the majority of genetics, does something actually, it's actually called epigenetics. That means that there are other factors that affect your genes. So you can carry both sets of the breast cancer gene, but you won't get it unless maybe you have a high fatty diet. Or with Alzheimer's disease, maybe you have the most common gene and all of a sudden you get a head injury. So that's going to increase your risk of getting Alzheimer's disease. Or your diabetes hasn't been well under control, and that's going to increase your risk. So the diabetes would turn or cause the gene to express itself, it's called. There's very few diseases. Huntington chorea is one of those where you carry both sets of the gene and you absolutely get the disease. So they feel that Alzheimer's disease is like that as well. So you may carry the genes, but something else happens, and it can be environmentally that we don't know yet that triggers the gene to express itself. So with Alzheimer's disease, the biggest problem is these behavioral and psychological manifestations, okay? They're actually called neuropsychiatric symptoms of dementia. So one of the things, and this is the primary thing that we treat. I mean, people can do fine seeing their family doctor for treatment of their dementia. They can go on the medications that sort of slow it down. But if they start having these, what you see on the slide, these symptoms of disturbed perception, thought, content, mood, and behavior, that's when they may ask a psychiatrist or a geriatric psychiatrist to see them. So those symptoms are like really bad depression, agitation, hallucinating. They may be real suspicious or paranoid and not think you're you may be feeding me poison food and things like that. That paranoid, that's called a delusion. They may be very agitated and restless, and that's when, and not sleeping, and there's nothing medically delirious causing it. So that could be part of the reason that the family doctor refers you. We usually don't see people that are just doing fine and have dementia. We see them when they're having these neuropsychiatric symptoms, okay? So if people don't get treated, people suffer, caregivers suffer, people may be institutionalized prematurely. There certainly are increased loss of care, and there's a loss of quality of life for the individual. And once again, for the caregiver as well, okay? So these are just, I left these in because I thought these would be helpful. These are the scales that we use. The MOCA, you actually have to be certified to use this scale, but the SLUMS is extremely similar. It's almost exactly like the MOCA. And I have a picture of, actually, this is what the SLUMS look like. So when you go into a doctor's office, this may be what they do. So what day of the week is it? What year? What state are we in? Please remember these 5 objects. and they ask you to repeat them 5 minutes later. And then they ask you some calculating things. And then simple things. How many animals can you name in 1 minute? And then what are the 5 objects I asked you to remember? And then series of numbers backwards. And then you have to do what's called a clock drawing. So you put the numbers on the clock and then you put the time of day. And many times people won't be able to get that right. Then it's naming the triangles. Okay, and then their story, you have to remember the story as well, and that's how you score it. So I thought that would be interesting for you to see that. And that is very similar to what most practitioners will do. So I'm going to move on to delirium now, and because I want to give you enough time. So individuals with dementia have a 5 times risk of developing a delirium. And just so you know, a delirium is a change in function, okay? And it's acute confusion. And delirium is the most acute condition of the depression to delirium and the dementia. All right. So that's the thing. If you see a change, that's when I say, when you see a change, you really need to think medical first. Okay. You need to think medical first, and you need to have the delirium looked at. That's the medical problem. So once again, the cardinal features of delirium of a recent onset of fluctuating awareness, impairment of memory and attention, and they're disorganized thinking. It is extremely common and underdiagnosed. It is the most common complication of admissions to hospitals of older individuals. It occurs in up to 42% of medical inpatient units and a half of older adults postoperatively. If we even have people go in for cataract surgery, one of our patients who have dementia, we actually do a letter and we give the family a letter to give to the doctor and say, my loved one this person has dementia. We are treating them and they may be delirious after they have their cataract surgery. So it's important for everybody to know that your loved one has dementia, especially if they're going in the hospital, because many doctors don't know that and many nurses don't know that as well. Okay. With delirium, it makes people stay in the hospital much longer. There's higher rates of nursing home placement and higher mortality as well. So people need to know you need to get delirium treated as quick as possible. Okay. With delirium, there is evidence from the medical history that there is something going on medically. It could be a substance intoxication. It could be a medication. It could be an infection. That could be the medical condition. It could be that their diabetes is out of control, things like that. Okay. And that's why you need to take these people to see their family doctor as much as possible. Now, medications frequently can cause delirium, but it's not going to be on a medication that the person has been on for 2 or 3 or even a month. It'll be a change in a medication. There's actually something that you can see where medications can cause older adults problems, but every medication is listed in there, basically, the Beers criteria. But the thing to remember, it's when the medication is changed. If the medication is changed and 3 days later, mom is not right, then it's delirium. And it potentially could be from the medication. So you really need to talk to the doctor about it. Okay, so medications can be a problem. Urinary tract infections, very common. I always say check urine. Catheters, respiratory infections, the flu, even constipation. I've had many patients from our clinic have confusion and hallucinations during the summer, and we take them into the hospital and they're dehydrated. Okay, alcohol withdrawal, pain, sleep deprivation, as I mentioned before, surgery, neurological disorders, environmental. I know the Alzheimer's Association will say if your loved one is going into the hospital, they think family should actually stay with them because the hospital can make them delirious. And I had a patient recently that their family member did stay with them. They were needed a blood transfusion, and the daughter stayed with her for overnight. Okay. So this is a definition of delirium from the DSM-5. I wanted to show you how it's broken down. So, and that's how this is. The DSM-5 is the book that psychiatrists use to diagnose. So delirium is the disturbance in attention, which is the reduced ability to direct, focus, sustain, and shift attention and orientation to the environment. And the disturbance develops quickly over a short period of time, from hours to a few days, and it is an acute change from baseline. So it's not just their dementia and they're having a bad day, it's an acute change from baseline. Okay, that's important to know. There's also a change in an additional cognitive domain, such as memory, disorientation, language disturbance, and it's not accounted for by a pre-existing neurocognitive disorder, which is dementia. Okay. All right, so that's how you tell. Risk factors for delirium: pre-existing cognitive problems, advanced age, hospitalization itself, once again, multiple medical problems, depression, the use of multiple medications, especially with those with anticholinergic properties. And I want to just emphasize a minute, many over-the-counter medications have anticholinergic properties. Tylenol PM has Benadryl in it, 25 milligrams of Benadryl. Okay. Benadryl is extremely anticholinergic. And one of the systems in the brain that is disrupted with Alzheimer's disease is the cholinergic system. So if you give somebody with dementia an anticholinergic medication, it's going to make them extremely confused and agitated. So using Benadryl, using Tylenol PM, Excedrin PM, that PM in all those medications is Benadryl. So we caution all our patients, the safest sleeping medication to use is actually melatonin. And you can check with your family doctor about that. Sleeping pills are not good for older adults, period. Okay. Anticholinergic medications are in bladder medications and things like that. So if you see a start, and before you give any over the counter, you really should be checking with your family doctor. Your family doctor, your primary care office should be checking about what medications you're using. Okay. General anesthesia can also cause delirium in older adults. Okay, and I'm going to tell you the story of my grandfather, who at 91, cognitively, my grandfather was very, very good. And just to show you how delirium can surface, he went in, he fell at 91. He used to walk a mile a day with his walker, but he fell at 91 and fractured his hip. So he ended up going into the hospital, get his hip replaced. I was the first person to see him when he was coming out of anesthesia, and he's laying there. And Shumakers are not wildly fun, spontaneously fun people. And I'm doing a mini mental on my grandfather. So I'm saying, pop up, can you tell me where you're at? And he's like, Harrisburg Hospital. Do you know what floor you're on? Well, I think I'm on the 6th floor. What day is it? He knew he was off by a day, but he knew it was July, knew the year, knew where he was. And we're going through, and I'm thinking, okay, he did really good the surgery, so he's not delirious. I was like, this is great. And then he said to me, but Lynn, there's one thing I don't understand. And I said, well, what is it, Pop? And he said, there were cowboys and Indians in the room with me this morning. And I said, Pop, I know you're not teasing. You're not one of those people. I said, no. That was probably the nurses and the doctors making rounds. And he said, no, Lynn, I saw them. I tell you, I saw them. And my grandfather was blind from macular degeneration, so I know he didn't see them. So it probably was the nurses and the doctors, but between the general anesthesia, his visual problems, being in the hospital, and having advanced age, he was delirious. Okay. Now, he wasn't distressed by seeing the Cowboys and Indians, which is probably a good thing, because he used to love Zane Grey novels and he loved reading those things. So he actually did really, really well. But that just to show you how complicated delirium can be. And with general anesthesia, you just sort of have to make sure they're safe, of course, and let it get out of their system. And sometimes it can take up to 5 days for it to get out of people's system. So, so visual problems can also be a risk factor, as is men are more at risk, and abnormal serum sodiums. So, and remember, like with women, urinary tract infections are extremely common, especially if people have diabetes. And women, the way we're made physiologically, as we get older, we dry, we all do, and we lose estrogen, and bacteria is more apt to be introduced into your bladder for women when you're wiping yourself when you go to the bathroom. So it's really important that you wipe from front to back, and you look for urinary tract infections in women. Okay, really, really important. So once again, symptoms: decreased short-term memory and recall, disrupted or wandering attention. People are really disorganized in their thinking. They can't focus on anything. Emotional or personality changes. They may become incontinent. They may be restless and irritated. Okay. Medications, infections, endocrine, metabolic, dehydration, constipation, anesthesia, trauma, alcohol, or sedative drug withdrawal. Now, I do want to also mention my mother got delirious in the hospital, and she at 82 was actually fine cognitively. And when she went in the hospital, she was seeing snow in the hall. And I kept telling the nurses, and this is so you can advocate for your loved ones if they're in acute care. I kept telling the nurses, my mother really doesn't have anything wrong with her memory. She's really oriented and fine. And they kept saying, yeah, she's 82 or 83. But her delirium was getting worse. So I would go in to feed her and she couldn't focus on dinner. So I literally took everything off her tray and just gave her a quarter of a sandwich. And that's how I got her to eat, because once again, she couldn't attend to the meal. So as it's getting worse, she is just restless, crawling out of bed. She is picking at her skin. And I'm sitting there thinking, why is she picking at her skin? And finally, it hit me. There was something going on with her medicine. And this was 3 days later, she is getting worse. And I went to the nurse on the floor and I said, she is much, much worse. I'm not sure what's going on. Can I please see her MAR? And she was skin picking. And skin picking is actually a sign of drug withdrawal. And my mother was on Oxycontin for severe degenerative disc disease, severe degenerative disc disease. You can tell I'm getting tired, a long day, end of a very long day. And her back, literally, when she died, was like in the shape of a Z. So she was chronically in bad pain and was on Oxycontin. And when I said that to the nurse, I said, can I look at her MAR, her med list? And she showed it to me. And I said, she is on Oxycontin, like 20 milligrams, at least twice a day, and then gets something at bedtime. And they said, oh, well, she's not in pain. And I said, you can't assess her pain because she is delirious. So I said to her, she's going through drug withdrawal. That's what skin picking is. Could you please, and then I called, she was in assisted living, and I called Messiah Village and I said, could you please refax her MAR to them because they don't have her on her Oxycontin and she's delirious from withdrawal. So they did that, and it just didn't happen. They weren't giving it. So finally, like 4 hours later, I called again and she still hadn't gotten it. So I called the evening shift supervisor and I said, this is pretty outrageous. I'm extremely angry. I'm a geriatric psych nurse. My mother is on has been on for 2 years a straight dose of Oxycontin for her disc disease. You guys have her on nothing, and she's now going through withdrawal, and this is bad. And I don't believe in suing hospitals, but I believe in educating you people. I want her to get this medication right away. She is suffering. She's going to be in the hospital longer because of this, because you guys weren't listening to what the facility was telling you and to what I was telling you. So you really need to advocate and watch and listen and make sure you know what's going on with your loved one. Okay. And it's your right to see, if you're the power of attorney, it's your right to see what's going on. You really need early recognition and treatment. And the key with delirium is identifying the cause. And for my mother, it was withdrawal. It may be a urinary tract infection, getting something treated. Okay. You need to make sure their sleep-wake cycle is good. And if they're in acute care, there should be, avoiding the use of restraints. You should be having somebody with your loved one all the time in the hospital. It really requires a multidisciplinary and person-centered approach. And those at risk are those over 65, those with cognitive impairment, with medical comorbidities, people with hip fractures, even worse. Okay. And there's assessment skills we use to assess for that. So the last thing I'm going to talk about, and hopefully get through this in 15 minutes, is, and this is a hospital type of approach that I actually like to use for families. And I actually this came from University of Iowa's nursing program, which is a very good program back in the 80s and the 90s. I actually worked with Jerry Hall, who is the co-writer of this article. But I want you to think about this. So it's called progressively lowered stress threshold model. It is a proactive approach, which is why I like using it with families, why I thought I'd give it to you guys tonight. It focuses on teaching us to identify, not just nursing staff, family as well, to identify and relieve stressors in the environment that cause the behavior. So there are 6 main groups of stressors that they identify that negatively affect people with dementia and can cause anxiety and disruptive behaviors. And they are, and think about this, fatigue, changes in routine, environment, or the caregiver, demands that exceed understanding or capabilities, multiple or completing stimuli, affective responses. That means they're feeling sad because they're feeling a loss, and it could be anger as well. And then physical stressors such as pain, constipation, or medication side effects. Okay. So with fatigue, I always think of my daughter when she was tiny. About 2 o'clock in the afternoon, she would get extremely irritable, and then I wouldn't hear anything and she would fall asleep. And one of the things, I love to take a nap in the afternoon still, if I have, now that I don't have a child at home. But some people need naps to take the edge off, especially if you're seeing people sundown. I think you've probably all heard of sundowning. Try taking people, have them take a nap in the early afternoon, or just getting some quiet time. Watch for changes in routine and caregivers and the environment. Okay. If you change a caregiver, you may want to be there the first few times to make sure there's a relationship and that's built and they trust the caregiver because they've seen the caregiver with you. I've had multiple families in our clinic who try to take their loved one on vacation to the shore or something, and that change of environment is extremely disruptive. They usually come home early. Okay. Other thing, which the 36-hour day talks about, is demands that exceed their understanding. It's called catastrophic reactions. So if you're asking mom to get in the shower tonight and they don't understand what you're saying, they may get agitated. If you're asking mom, excuse me, you maybe get dressed, they may not understand that. Say that she has you're taking your mom to an early morning doctor's appointment and you're saying, Mom, we have to hurry, please get dressed, let's keep going. That's going to increase their agitation. That's going to increase their anxiety. There's multiple competing stimuli and they're going to lose it. They're going to have a catastrophic reaction and get extremely agitated. Okay. So in the physical stressors, that once again is the delirium. So you need to be aware of all of these things. We need to maximize safety by modifying the environment to compensate for their losses, to make sure their stress level is low, to really support them. Okay. Watch for factors that increase their stress. This time of year, I always say, even though you may not have a wild holiday party, there is a lot of emotional energy in the air that sometimes can upset people. Okay. You also want to make sure you have a consistent, structured routine. We have a family right now who brought their loved one home from a nursing facility. She was there after fracturing her hip for rehab. And one of the things we stress to him is really to please make sure that there is structure with the family. Okay. Implement regular rest periods and provide unconditional positive regard. Once again, always be positive. The Alzheimer's Association, I love this, for years actually said you never say no. So instead of no, Dad, I don't want you to go out that door, say, hey, Dad, why don't you come help me do this? Okay. I hope that makes sense to you. Remain non-judgmental about the appropriateness of all behaviors except those that may pose safety risk. Make sure that everyone knows that mom needs a nap or she gets agitated in sundowns, okay? Share that with caregivers. If they go into the hospital, make sure nursing staff know that. Provide reality orientation. Dad, this is the hospital. I'm staying with you tonight. You're having your cataract surgery, things like that. Okay. Use music, use reminiscing, talk about really positive things from the past. Do photograph albums. Okay. We had a couple in a facility, they were in the same room, and both of them had Alzheimer's disease. And they would start arguing and fighting because both of them were remembering, and the staff just did not know what to do. And finally, the one social worker, who is a good friend of mine, walked back to check on them because they were thinking that they needed to move their rooms and separate them, which the family really didn't want to do. And the social worker went back in to talk to them, and she found their wedding photograph was sitting on the dresser in the room. And she picked it up because they were fighting again. She picked it up and said, is this you two? And they just started laughing and giggling and talking about their marriage and their early, and that's what the staff used. That became their behavioral approach. When they started fighting, they went in and picked up that photograph for them to talk about and to reminisce about. That was the thing that they did. So in conclusion, before we open this up for questions, people need good medical care. Medicare does, through the Affordable Care Act, actually has a free wellness visit every year. Please use it. What my mother used to do is take her bag of medicine and take it into the doctor and say, can you please get rid of something? Okay. There are blood tests people look for to make sure people aren't delirious. It's a CBC with a differential, looking for infections, looking for dehydration and things. Thyroid studies, B12 and folate, a basic metabolic rate or chemistry profile, RPR, urinalysis, of course, sedimentation rates, look for infections, certainly psychiatric assessments, neuropsych or psychological testing, evaluate functional abilities. I have many people with moderate stages of dementia who still help around the house doing dishes. They still cook. I can tell you, we had my grandmother would help peel apples and potatoes at holiday dinners. And of course, we can't forget social factors. That is why that is last, because you need to make sure you as caregivers are not depressed, that you're functioning well, that you're getting plenty of sleep and support, that you're getting respite in the community. Okay. So questions.
Hi, Linda. One of the biggest questions was whether or not you'd be willing to share your slides.
Yes,
presentation.
that's fine. You can, Jane can pass them out. Yes.
Great, thank you. So I'm going to go back to depression. I was logging all of these questions. Since there's an increase in depression due to social isolation and the pandemic, and it's really been a struggle for long-term care residents, nonetheless, the rest of us,
Yes.
do you have any suggestions on combating that social isolation and the risk for depression in general in long-term care?
I think hopefully everybody's going to get their vaccine soon in long-term care, including staff. One of the things, if they do Zoom visits, we have a couple facilities around here who are doing window visits and Zoom visits to keep that contact up. Phone calls, I can tell you, I have good friends, retired doctors that I worked with for a long time, who they were moving to California, but they got stranded in the Adirondacks, and they're very rural. We're very, very rural up there. And we actually do Zoom calls and phone calls. So even a phone call is important. One of the other things, actually, National Public Radio, if I find that link, I'll send it to Jane to send out. They had a really wonderful thing about sending cards to people and scheduling all sorts of things like that, like sending things weekly to make sure you're maintaining contact. Those types of things are really important. I know some facilities now are sort of opening up a bit and holding some groups and some meals with limited residents at times. But sending mail, sending cards like that, phone calls, just those simple things is very important. I actually did a presentation with MH and COVID, and people were saying, well, what can we do to volunteer? And I'm like, contact your local nursing home and just call people and talk to people and, do life review and reminiscing if you can, those types of things.
Sure. Along those same lines, there was a family member who messaged that her father has had lifelong depression, and he always coped as well as he could with social interaction, hands-on physical activities, and that became more difficult when he moved into a memory care unit, but even more so now. That is a major challenge that our residents are faced with. Right. And there's limited activities as there are, but now she's concerned that he's heavily medicated. She can't tell if he's depressed or if he's just medicated, because no one can get in to access these residents in person and really get a better feel for things. Yeah. So if you have any advice there, I know that's...
The only thing I can suggest is have him evaluated, see if they have any psychiatrists going into that facility that could see him. Some places do have psychiatrists that go in, but as soon as possible, as soon as he's able to get seen, I would have them set up an appointment with somebody to see him, especially if he has a history of depression. And I didn't mention exercise, but I am one of those people. I have a genetic, I really have a loaded genetic pool for depression, and I'm an old runner, and physical exercise is how I maintain my mental health. And I've never gotten a depression. Okay, so I agree that is very, very helpful. And I think facilities, I actually worked with a long-term care facility, and we implemented walking programs to help prevent agitation and depression in dementia patients in that facility.
Do you have any suggestions for family members who are struggling with their loved one's refusal to even acknowledge that they have depression, or seek or accept any treatment or speak with a specialist of any kind to really break that barrier?
Sometimes it's, especially with this generation, it's extremely difficult to break that barrier. Stigma is really, really huge. That's why I always tell people, even when I talk to people, I say, I don't say, are you depressed? I'll say, are you feeling sad or blue? And one of the things is to give the family doctor a call under the table and say, I really think they're depressed. Can you assess them for that? The family doctor can assess them and maybe prescribe something. I mean, people, and you can say for your nerves or things like that, it's a real hard bridge. And you can, I think what I did with my mother, and my mother finally recognized she never wanted to go off her antidepressant after she stopped taking it that one time. But you can go online, and University of Pittsburgh has very good education materials. So does the National Institutes of Mental Health with depression. The Geriatric Mental Health Foundation sources that you can use to educate people, but sometimes even with all that material coming, it does not help. It's very, very difficult. Yeah.
Hi,
Are you-
Linda. This is, oh, I'm sorry.
No, go for it.
I'm sorry, Corey. We do have a hand up. Charlene, go ahead, please.
Yes, thank you.
Sure.
I think, Linda, you mentioned that there, for late onset dementia,
Late onset depression.
depression, I meant to say depression, I'm sorry,
Yes.
to make sure that it's not thyroid related. And
Yeah.
I have a family member that was recently diagnosed. She has depression and has for some time, but was recently diagnosed with a thyroid benign mass. She's had several things happen, hip fracture. So I'm just wondering, since she is not at her pre-pandemic state and she's not responsive at all, could it be the thyroid? How does the thyroid interact, and what is the correlation between thyroid problems and depression?
Okay, so was she depressed before the thyroid?
I had not seen her for 8 months.
Okay.
To my knowledge, she was not depressed pre-pandemic, prior to March.
So what they could do is they could treat her thyroid and just see if the depression goes away. But if she has multiple medical problems going on, it's not just going to be one thing that's causing the depression. It could be the multiple things causing the depression and plus the pandemic. So she's got multiple stressors going on. And it's not like you can just fix one and it's going to stop the depression. Does that make sense at all?
Sure. And the
Yeah.
other question that I had is about the Cornell scale. Can you explain what that is?
It actually is. And these scales should be done by professionals, but the Cornell scale actually is a very simple scale that you can use to assess depression in individuals with dementia.
So I can find that online.
All you have to do, you can Google these things and you can find them online. And as far as I know, that one is not copyrighted as well.
Thank you.
You're welcome.
There was a comment in the chat about the slums and that didn't appear to be as effective or as accurate of a scale. Do you have any input on that?
No, the slums is something that we use routinely and it's very accurate.
Okay. The next question in the chat was in regards to major mental health conditions, schizophrenia, bipolar, etc., that appear to be stigmatized and deterrents for long-term care communities to actually accept that resident in the first place.
Mhm.
So they were asking for some input on any statistics on co-occurrence of that and any major geriatric mental or cognitive health conditions. If you've noticed any issues there, or what can we do to reduce the stigma there?
So is the issue related to stigma in long-term care, or is the issue related to stigma generally?
It was more about long-term care and the challenge that the staff are not properly educated and compassionate about these.
Right. So this is actually my graduate work. Okay. So long-term care facilities are not psychiatric facilities, unfortunately, but many people, not just people with mental health problems like schizophrenia or manic depressive illness, but people with dementia, 90% of people with Alzheimer's disease and dementia get psychotic at some point during their dementia process. Staff in long-term care, both nurses and nursing assistants, are not adequately trained to work with residents. And that is the way it has been for an extremely long time. And they aren't adequately educated, nor do they have the resources to get psychiatrists in nursing homes. Now, one of the reasons that individuals with schizophrenia and bipolar disorders and major psychiatric illnesses are sort of flagged going into nursing homes is because they want to make sure they have access to care, to adequate care to their mental health concerns. So, and that's unfortunately in the state of Pennsylvania for probably 5 or 10 years. I actually worked with both the Department of Aging and the Office of Mental Health, and we had memorandums of understanding where people would work together and we could talk about these problems because they're huge problems. And that sort of fell apart in 2015. So that those memorandums of understanding that each county had to have, as well as the state, so we knew people were talking, that could bridge some of this. And that has not happened. Now, under COVID, things have gotten much worse, and a whole lot of these systems falling apart are being exposed, unfortunately or fortunately. So I think that, and I actually got a phone call from the Office of Mental Health a couple of weeks ago about people with dementia being psychotic, and what do I know about that? So we also, so it's a huge problem on multiple layers, and I could not answer it in a week, let alone on this call. So, and the only thing we can do is advocate for change is all we can do.
Linda, we do have another hand up. Peg, go ahead.
Myself. So that was my question. And we know of a person who has struggled with bipolar since the age of 19 and is now 78. So it's well managed. And but the very fact that that medication, as well as in fact, that is the only medication that that person receives to maintain his very good status. But there was something about the very mention
And
of bipolar disorder that, I don't know, it just seemed to raise eyebrows and hackles. And this is a family with bipolar is more genetic than some other major mental illnesses. So we know all about this stigma and this eyebrow raising. So, but we weren't braced to see it in this setting, but it's fine now. It's person by person, situation by situation. You just have to be patient and wait. Thank God he wasn't turned away just because of that, so.
And I think the thing you do is you advocate, because
exactly, yeah.
You advocate, and we have many people in our clinic with chronic mental illness who are in facilities, but facilities, they're pleased because they're seeing a geriatric psychiatrist, but it's not, they're stable, and people need to know that. And it's really the system that messed it up. It wasn't the nursing home. Nursing homes it's just going to flag them. It didn't start with the nursing homes. It started with I forget which higher level that it started, but they were trying to make sure that nursing facilities had proper treatment for people with chronic mental illness. So once again, it's one of those things that started out as a positive and ended up being a negative. And one of the things I want to add about facilities right now, because I worry about the staff in long-term care a huge amount right now, because they're working shorter, they're doing horrible jobs in the midst of a horrible pandemic. And I know they love the majority of them love their residents and are so sad about all this. So we need to support them and be kind to them. And really, I have the one social worker that I work with whose mother we treat in a facility. she's been dropping off cheesecakes and pizza every other week to the facility because she knows that staff is so exhausted from dealing with COVID and isolation themselves. And we really need to be aware of that. And we need to work on it. And I hope you guys take this, really advocate for your loved ones and advocate for the facilities that they're in, that things need to change. It's not the staff's fault. It's the system. It literally is. And trust me, I've sat in many, many meetings and I was the main voice saying, this is not right. The reason I know about long-term care facilities is when I put my way through graduate school working every other weekend in addition to during the week. And they loved me at that facility because I was a psych nurse. So we've known for years that it's not good in facilities. And back in 2003, I can tell you, we did some major things in 2005 that we were trying to change the systems, get them to work together, to talk to each other, to share. A lot of my education over the years has been in long-term care.